Today, our topic is infections of the bone and the joint. Good morning, everyone. My name is Sanzong Xu from the First Affiliated Hospital of Medical College, Zhejiang University. Today, we are going to talk about the infections of the bone and the joint. This is the X-ray for the osteomyelitis of the typical young child. We can see a lot of abscess here in the bone, and here also abscess and necrosis of the bone. Okay, so this we call the osteomyelitis. The osteomyelitis, we got a definition of this is an infection of bone or bone marrow involving the osteum and the cortical bone and the medullar cavity. The epidemiological trial, we see the disease is a result of forces within dynamic system, consisting of the agent of infection, the host, the environment, and all the triangles versus this disease. The factors influencing disease and transmission. We see the agent is here, and the environment and the host. And there are a lot of factors listed in these places. They all involving this disease. The bacteria, as the osteomyelitis, we see the staphylococcus aureus in 80% to 90% of the cases. The E. coli and their pasteuromallus and their Klebsiella in patients with genital urinary tract infects and the drugs abusers. We also know the neonators, the hemophilus influence and the group B streptococcus. In patients with sickle cell disease, salmonella infections also were involved in this kind of osteomyelitis. There are different age groups of this disease. We can divide it to newborn, means younger than 4 months, or the children, adolescents, and the adult, and the sickle cell anemia patients. This was not divided for the age group because of this kind of disease is associated with salmonella species, the most common in the sickle cell disease and very unique to sickle cell patients. So we can take a look at this table. We see a lot of the patients was associated with S. aureus. This was the main bacteria for this osteomyelitis. So in children, the round bones are usually unaffected. In adults, the vertebral and the pelvics are most commonly affected. Also, we can see the difference of the bacteria from the post-traumatic infections and the post-operative infections and the procedure infections. They're quite different, and we can use different kind of drugs to cure this kind of bacterial infections. And we also got dog and cat bite. We use ampicillin and amyloxicillin and other drugs to use to cure this kind of infections and the traumatic exposure to the marine life. This slide, we are going to talk about the osteomyelitis classification. If we classification from the location of the osteomyelitis, we got pyrogenic osteomyelitis and septic arthritis. If we classification using the duration of this kind of disease, we can divide it to acute osteomyelitis and then the chronic osteomyelitis. We classify this from the root. We got hematogenous and traumatic and contagious spread osteomyelitis. We got a differentiation between osteomyelitis and septic arthritis. The first we can see the septic arthritis, absolutely no movement is permitted to the joint, and the osteomyelitis, there were minimal function of the adjacent joint remains. Here is the picture for the location of different diagnoses, and the places which was yellow here was the main positions that osteomyelitis were involved. And we also see a lot of tumors may be occurred in this kind of skeletal system, like the uvens. We got the around the knee places. The duration of the infection. Just as we talked about before, the duration of the infection, if we classification to the acute one, the subacute one, and the chronic one. And some books may be not say the subacute as this kind of classification, but we always traditionally classify to these three parts. And the acute one was less than 2 weeks. The subacute one was 2 and 3 weeks, and the chronic one was always longer than the 3 weeks. The pathology. We know the acute osteomyelitis was always involved infiltration of PNNs and congested or thrombosis vessels. And the chronic one, however, was always the necrotic bone and the absence of living osteocytes and mixed inflammatory cells predominate of disease. And how the acute osteomyelitis change to the chronic osteomyelitis? There are many factors. Always we can divide to the local factors and the general factors. And the local factors was presence of foreign body, the bone necrosis, the heavy contamination, the bacterial slow metabolic rate, and convert in slime and hide intracellularly, and the host defense defected. Also, we take osteolytis as the local factors, and the general factors that was very common for the clinic. First one was diabetes. Diabetes can cause acute osteomyelitis change to chronic osteomyelitis, and the peripheral vascular disease, and the obesity or smoking sectors will cause acute osteomyelitis to chronic osteomyelitis. This slide will show the pyogenic osteomyelitis. The first thing we should know is pyogenic osteomyelitis was always caused by bacteria. And the roots of the infection, we divided to the 3 parts of this osteomyelitis. The first is hematogenesis spread. This was the most common roots of the infections. And the second one was cotigenous site. And the third one was direct implantation. By far, the hematogenesis route is the most common one, as we see. And the pathology, the infective process usually begins in the metaphysis. And here are the pictures of these metaphysis infections, and we generally developed into the joint of this intercatchable joint, and we know the infections can change and as their pathology developed. How does these things happen? First, we know the organisms once localized in bone, and the bacteria proliferate and induce inflammatory reaction and cause cell death. We know the bone undergoes necrosis within first 48 hours, and bacteria and inflammation spread within the shaft of the bone and may percolate throughout the Haversian system and reach the periosteum. And generally, we know the subperiosteum abscesses. This kind of things happened means abscess forms and the infections of this bone, which can be diagnosed from the X-ray. And the segmental bone necrosis to the sequestrum, which means dead piece of bone, and the rupture of periosteum leads to an abscess in surrounding soft tissue and the formation and draining sinus. Over time, the host response develops. After first week of infection, chronic inflammatory cells become more numerous, and the cyclotins from leukocytes stimulates osteoclastic bone respiration to ingrowth of the fibrous tissue and develop to deposition of reactive bone in the periphery. And reactive whorf or laminar bone, which was formed, sleeves of living tissue surrounding dead bone, is called as invacuum. We got pictures of osteomyelitis growth, and this is the X-ray for the osteomyelitis. And we got a microscopy pictures of the osteomyelitis. In the microscopy, we see which was the secondary was necrosis bone, is like this. And the invectrum always means the new bone. We can see the picture here from during the operation, and the picture here is from the microscopy. And this one was a new bone. The mechanism of infection. We can divide the infection to the exogenous and the hematogenesis mechanisms. The mechanism of infection can exogenous or hematogenesis. And exogenous osteomyelitis is caused by open fractures always. And the surgery, of course, or cotigenous spread from their infected local tissue. The hematogenesis form result from bacteria. So we got so-called traumatic osteomyelitis. That means an open wound of the bone can lead to osteomyelitis. This happens most commonly with underlying peripheral vascular disease and the peripheral neuropathy or diabetes. which an open fracture combined fractures means the bone that punctures through the skin is exposed to bacteria. This increases the risk of osteomyelitis. And the third one we should know is a recent surgery or injection around the bone can also expose the bone to bacteria and lead to osteomyelitis. We got another classification systems which was used by Wadiberger, and this was can divide to osteomyelitis to the 4 parts. And the first one was cartilaginous spread osteomyelitis, and the second one was direct extension, as we said, and the acute hematerogenous osteomyelitis, which is very common, and the peripheral vascular disease, which always associated with diabetes. We see this one by one. First was cartilaginous spread osteomyelitis. This kind of osteomyelitis is most common way of developing osteomyelitis in the feet. Is from cartilaginous spread. This is where an existing soft tissue infection eventually spreads into the bone from those infected surrounding tissues. And their direct extension. The first mechanism of infection is when osteomyelitis develops from a direct implantation of bacteria into the bone from outside of the body, a process known as direct extension. And a good example of this will be a patient stepping on the nail with the nail transmitting an infection directly into the bone. And also we got acute hematerogenous osteomyelitis. Another common way of developing osteomyelitis is from spray from the elsewhere in the body, and in this case the infection is seeped into the bone from the blood supply. This is often categorized as acute hematerogenous osteomyelitis, which also we call it hematerogenous osteomyelitis without acute, but this one was always acute. And the hematerogenous osteomyelitis, we know the most common type of the bone infection is hematerogenous osteomyelitis. It's about 85% of patients with hematerogenous osteomyelitis and are younger than 7 years and are accounting for 20% of the total case of osteomyelitis. The peripheral vascular disease. The osteomyelitis, as a result of peripheral vascular disease, always associated with the poor circulation, and it is most commonly seen in the diabetes. Clinical features. And this slide we are going to talk about the clinical features of the osteomyelitis. The classic presentation of the osteomyelitis was always a sudden onset for an acute type. If that was chronic, it should be an acute type in form. And we got high fever always, and the night sweats, and the fatigue, and the axial retraction, the weight loss, the restriction of the movement, the local edema, and the tenderness is all the things. So these are the clinical features for this disease. The investigations. We can also use lab studies to diagnose this kind of disease. First, we always use the WBC, means maybe variated and usually normal. And the C-reactive protein is can provide a lot of information for this disease. And we also got ESR, and